Good morning. This is Patricio Gonzalez, pediatric anesthesiologist from La Paz Children's Hospital in Madrid. And today I'm going to speak about effective alveolar recruitment maneuvers in pediatric anesthesia within the symposium organized by Mandray about safety anesthesia. So I would like to start my presentation with Anna, who's a 13-month-old, 9 kilos infant who is scheduled for surgery. She was previously healthy and only had a minor upper airway infection 6 weeks ago. Now, we did scan her with a long ultrasound in the lower dorsal quadrants on both left and right, and this is what we found. The patient is awake, moving, that's before anesthesia. So she's fully awake, normal saturation, and the lung examination is normal with A lines and pretty much anything else. And this is the same patient examined before extubation, same quadrants, and you can see that on the left side there's some collapse, grade 2, and on the right side a little bit more severe collapse, grade 3. And that happened after 60 minutes surgery. The saturation, as we said, before surgery was 98%, and after surgery and after extubation, it was 93%. So what happened, right? As you probably guessed, the patient had atelectasis, preoperative atelectasis. And that's because between 68 to almost 100% of our patients develop atelectasis after induction of anesthesia, especially newborns, infants under 3 years of age, obese patients, patients who have sick lungs, especially PRDS, or patients who need high FAO2 to maintain saturation during surgery or during the ICU. And as Hans Sierna, who recently passed away, described very well during his whole career, the higher the FAO2 we provide, the more likely that absorption atelectasis may occur. And this atelectasis may persist for several days post-operatively. They suppose a risk for infection and respiratory complications, and they, of course, suppose they suppose a shunt mechanism. This meta-analysis published some years ago about the outcomes of recruitment maneuvers in adults and in children. It showed that recruitment maneuvers improved intraoperative oxygenation. They decreased the need of high FAO2. Recruitment maneuvers enhanced recovery after hypoxemic events and decreased post-operative pulmonary complications. So authors, after this examination and during the meta-analysis, recommend the routine use of recruitment maneuvers after anesthetic induction, and propose the use of PEEP to all patients to avoid lung collapse during surgery. And recruitment maneuvers prevent lung injury associated with tidal recruitment and atelectrauma. So, which patients might benefit from recruitment maneuvers? Well, as we said before, those who are under 60 years of age or above 30 years of age, obese patients, surgery that implies laparoscopy, or some other positions like Trendelenburg position or thoracic surgery, heart surgery, or abdominal surgery, which all suppose a risk for lung collapse. We might have worse outcomes after recruitment maneuvers if the patient has a late ARDS situation, because the lung is very stiff and it's not so will not respond so much to recruitment maneuvers, most likely. All processes that suppose that the lungs are not homogeneous, such as unilateral pneumonia or focal changes in ARDS. Lungs which are very stiff, as we said before, such as ARDS that require high PEEP or low chest compliance. Patients who might resist very well collapse, such as those who are between 6 and 25 years of age, and lung diseases such as COPD or emphysema. Probably emphysema is a very, very bad idea to perform a lung recruitment maneuver. And it might not be a good idea if the patient is in shock, recurrent high inotropes, the patient has high ICP or traumatic brain injury, is going to be operated for open eye surgery, has pneumothorax, which is not evacuated, has not been evacuated yet, has pulmonary bulla or lung emphysema. This is a very nice picture of a congenital emphysema. And patient has an active bronchospasm, which is a very bad idea to do a recruitment maneuver. So how do I do it? Classically, we've done probably most of us have at some point of our careers have done sustained CPAP with 40 centimeters of water for a time between 8 and 40 seconds. We do not longer recommend this in pediatrics because of the high risk for hemodynamic impairment. Same thing happens with high pressure consecutive sides. High pressure 50 centimeters of water in 3 to 6 breaths. That might suppose high risk for hemodynamic impairment, especially bradycardia. So we propose staircase recruitment maneuvers that we are going to comment a little bit more thoroughly. But recruitment maneuvers, they depend on pressure. As Jova Borges described, in adults with severe ARDS, if you achieve, if you go up to 55 centimeters of water, you most likely recruit 85% of your patients. That's a very high maximal pressure, but you know that the higher the pressure you apply, the most likely you're going to recruit the patient. Not always, but the pressure is a key element. And not only pressure, time is also essential. Allowing enough time for the pressure to inflate the lungs, that's also essential. And we are going to discuss a little bit more on that later on. So we have another patient here who has just came to our PICU. It's a 6 kilo infant who has just been operated of tetralogy of Fallot, and is saturating 94% on 0.6 oxygen with a SF ratio of 156 and a compliance half of the expected 3.0. And now we perform a lung ultrasound and discover that the patient has atelectasis, consolidation grade 3. This is on the lower left lower quadrant, and apart from the atelectasis, we see pleural effusion here, pleural effusion and air bronchogram. So we decide that we're going to recruit the patient, the lungs. We start with pressure control with a P5 and driving at 15, and we slowly go up in pressure. See what happens. Now we have 30 centimeters of water of max Pmax. We still have pretty much a pretty big collapse, and of course the same pleural effusion. So what do? Do we stay here? Do we continue? The saturation has improved from 94 to 97. The compliance has doubled from 3 to 6, and now has the expected per wave compliance, dynamic compliance. But if we check the lung ultrasound, it gives us information that it might be worth continuing the lung recruitment maneuver. So we do that. We raise up to 40 centimeters of water. Now the compliance has decreased a little bit, and the compliance, sorry, the saturation has improved even a little bit more. So we have 5.5 from 6 that had with 30 centimeters of water, and saturation went from 97 to 98. So now we stay there for some time until the recruitment maneuver is completed. And this is what we see with 40 centimeters of water. Now there's almost no collapse, but poor aeration. That's B lines are or stick together, sign for poor aeration, but the collapse is almost gone, and we still have, of course, the pleural effusion has not been drained yet. So we stay there for some time, and now it's time to select the optimal peak, the ideal peak for this patient. And to do the PEEP titration, we either stay with the same pressure control mode, and I recommend to lower to a driving pressure of 10, just to prevent having very high tidal volumes on the way down, or you select the 6 ml per kilo strategy in your desired ventilation mode. And now it's time to select the optimal PEEP and see what happens in compliance and saturation and lung ultrasound. And see that the compliance improves again. So we have gone away from the overdistinction zone, and the saturation keeps improving. And this is what happens in the lung ultrasound. We see that in a 13 centimeter water of PEEP, we still see almost no collapse and still some poor radiation. And if we go a bit farther down, we go back to square one. That means that we have lost our recruitment. And that happened with a PEEP of 11 and especially PEEP of 9. See collapse here and here with a brochogram. So we know now that the PEEP is slightly above 11, and that so we need to do the recruitment maneuver again. Preservation phase 20 over 20 for some time, and we'll discuss later on. And then we select the ideal PEEP for this patient, which is 12. With the open lung, with the protective ventilation strategy of 6 ml per kilos and our desired ventilation mode. And this is what we see: very little collapse, almost none, and much improved aeration now after the second recruitment maneuver. So what's my maximal pressure target? We can use clinical experience depending on the context of the patient, the hemodynamics, the lung status, if the patient is in the ICU or has RADS, or the patient is in the operating theater, has a laparoscopy, or the patient is in prone position. These are all contexts that actually matter and may help us decide if we can go to a higher pressure or we maybe stay in a more safer zone. But anyway, we usually select between 35 and 40 centimeters of water in mostly all of our patients, unless they are very sick. It's important to see what happens in the compliance trends. That gives us a lot of information to select the Pmax, and of course to select the optimal PEEP. But I also recommend you to see what happens during the recruitment maneuver in the saturation. Please take a close look at what happens to the pulsosimetry. Now that we have available automatic recruitment maneuvers, we can have more time to watch what happens with hemodynamics and saturation. And it might give us a lot of information about our patient, the hemodynamic status, and the lung recruitment maneuver outcomes. And of course, lung, as we said, we saw before during our recruitment maneuver in our patient, lung ultrasound gives us a lot of information about when to stop, and maybe if we need to continue the recruitment maneuver later on. So what's the target? Again, this study done by Tusman and Cecilia Costa, tailoring recruitment maneuvers in kids using lung ultrasound. They describe that it's easy to tailor opening and closing pressures and selecting optimal PEEP, just as we've just done in our patient. And they describe that in a different team from South Korea, they described in this randomized controlled trial in kids that if where they did two recruitment maneuvers, one after intubation and the second one before just before extubation, and they saw that if you stick to 30 centimeters of water, you are missing a lot of lung to recruit in most of our patients. So you most likely need to go up to 35, even sometimes 40%, 40 centimeters of water to successfully recruit your patients. If you stick to 35, you see that you will get almost 85 of your patients fully recruited before extubation. And lung ultrasound give us information about lung ultrasound guided recruitment maneuvers imply less intraoperative atelectasis versus control group, and also less post-operative hypoxemic events versus control group. So it's a nice way to tailor recruitment maneuvers, especially in pediatrics. And talking about time, how long do I hold this Emax? Classically, we've used 10 to 30 seconds if the patient is stable in hemodynamics, and that is 5 to 10 breaths. And that's important because lung recruitment depends on time, on pressure, not only pressure, but time. And I will talk about this now because Gary Neiman, back in the 80s, described very well how the lungs are recruited. And him and his team described it that the lungs open usually 75 to 85% in the first 2 seconds in an avalanche phenomenon. So 85% of the alveoli open in the very first 2 seconds, but you're still missing some alveoli. So if you see now, whoops, they open in the first 2 seconds, most of the alveoli, but you still have some lung who is not fully recruited. And please look closely here and see how as the time goes by, you will see that the alveoli will open up. This again is a stunning classical study by Gary Neiman and colleagues. It's beautiful how the alveoli open up. Whoop, now you got it. 30 seconds, and still you have some room for improvement, right? So they recommend at least 40 centimeters of water to expect fully alveoli recruit. Again, 40 centimeters of water, 40 seconds, that's almost 100% of your alveoli open. And that's why they recommended back in the days a CPAP of 40 centimeters of water during 40 seconds. But in pediatrics again, you are risking the hemodynamics with this approach. So we now recommend 40 centimeters, 35 to 40 centimeters of water during 40 seconds in pediatrics. And now we are going to talk about my personal recommendations. That's all these slides showing Pikachu. That means that that's mostly my impression, my recommendation, and not solely based on clinical trials or evidence. So again, if you are in the operating theater dealing mostly with absorption atelectasis, do your recruitment maneuver when you think it's most suitable. And please individualize using lung ultrasound if you have it, pulsimetry and compliance, and hold your pressurization phase for 30 seconds to 1 minute if the patient is stable enough. And if you are in the PICU and dealing mostly with sticky atelectasis, which are more difficult to recruit, again, individualize with the means that you have available and according to local protocols. And you might need to hold your pressurization for a little bit longer, that is 1 to 2 minutes if the patient is hemodynamically stable. And how about setting a PIP? That's a classical question. And in an ideal world, you will do it according to a PF ratio and a PV curve. That's not something that you most likely have available in the clinical setting. And then there we usually use the compliance, and we set the PIP 2 centimeters higher than the PIP that matches recollapse during the compliance trial, as we saw in our previous patient that had a collapse PIP of 9, 10, and we selected a 12 PIP as an optimum PIP according to compliance and according to lung ultrasound. But now EAT is more available, and that will be probably the gold standard in the next few years, and give us information about overhead extension and about collapse, and give us the means to better select the optimal PIP and individualize on each position for the same patient during time. So I'm looking forward to having EAT more spread in the PICU. And sorry about this slide, which is in Spanish, but how about the respiratory rate? Which respiratory rate do I program? So I recommend you to watch what's happening in the flow time curve. And it's important that both inspiratory and expiratory flow reaches 0, especially expiratory flow reaches 0. And that will prevent auto-PIP during lung recruitment. But Both ideally should aim 0. And do I need to change my FiO2? Well, if you are in the PICU, my recommendation is that you stick with the same FiO2 if you can. And if the patient is very sick, for safety reasons, better that you raise it to 1.0, the FiO2, just to prevent that the patient might deteriorate in the oxygenation during recruitment maneuver. And if you stick with the same FiO2 and the saturation is between 92 and 97, you might have the opportunity to watch what's happening in the saturation during the lung recruitment maneuver. And I strongly recommend you to watch and see what happens, especially with the automatic recruitment maneuvers that we have. You have more time to watch for changes and for improvement. And maybe if you reach about 97% of saturation, you won't need to raise your or continue your recruitment maneuver further along, because maybe you've already reached the lung recruitment. And if you are in the OR, you either stick to the same FiO2, or maybe try this new concept of air test, which was first described by Carlos Ferrando. And using a 0.21% of oxygen in a healthy lungs, you can see if the saturation drops and what happens during the lung recruitment on the same rationale. If the saturation improves about 97, maybe you can stop recruitment maneuver only with a 25-30 centimeter of water Pmax. So that was the idea of our latest clinical trial, where we recruited 8 patients under 18 years of age, where the basal saturation was about 96, and they did not need oxygen before anesthesia induction. And we wanted to see what happened with the air test, and see if we air test, that is 0.21% oxygen, could detect atelectasis during surgery. So the median saturation in our population was 99%. They were mostly healthy lungs that we were dealing with, and the lung ultrasound score was 0. That means that the patient was had A lines and no major abnormalities, using the Acosta scale. We did the first air test right after anesthesia induction, and the saturation dropped to 96% in our patient population. Unfortunately, we could not assess the lung ultrasound here because the surgeons were in a rush, and they usually did not allow us to do a second ultrasound at this stage. But we did that right before extubation, and the air test was the same. The median saturation was 96, and the lung ultrasound score went from 0 to 6. That means that the patient had some level of collapse and or poor aeration. And further on in the PICU, the patient had 96% median saturation, and upon discharge in the 4th air test had a median saturation 98. That means that mostly all of our patients left the PICU breathing somewhat worse than when they get to the operating theater. Again, this is preliminary data. We still have not fully processed it, and we still need to publish it. So it needs to be under peer review. But there's some new concept I wanted to introduce to you, because we need to use our brains. We need to reuse our head, and it's important that we understand what we do and the risk associated with the lung recruitment maneuvers. And this is my question to you now. What is the maximum pressure that you believe is likely to cause pneumothorax in healthy newborns? Is it 30 meters of water, 45, 55, or pressures above 60 centimeters of water? Well, we did look for that some years ago and published it in Respiratory Care, and we discovered that we found out that the 90 centimeter of water was the medium max pressure that caused pneumothorax, and the pressures range from 65 to 70 to somewhat above 100. And we use piglets also, of course. I did not mention it, but of course we did not use kids, but 3 kilos piglets. And they all unfortunately died before pneumothorax occurred due to severe hemodynamic impairment. And we watch this box plot about side effects. You can see that in green, this is the group that we ventilated using a staircase recruitment maneuver. And we described that the pneumothorax pressures were way above the usual Pmax used for recruitment maneuvers in operating theater or even in severe ADS. Asystole, again, way above the usual pressures needed in the PICU or in the operating theater. And we might face hypotension in some patients with high pressures above 40-45 centimeters of water. And if we stick to staircase recruitment maneuvers, bradycardia is very unlikely to happen, in contrast to the maneuvers that we mentioned before, such as CPAP or high pressure in a consecutive breaths. And just to end this presentation, I would like to remember Robert Kamarek, who also recently passed away early this year. And they studied the open lung approach versus the RDS net with 200 adult patients with RDS, and they studied what happened with the lung recruitment maneuvers that were performed up to 55 to 60 centimeters of water and high PEEP levels. And the conclusions were that our open lung approach using recruitment maneuvers improved oxygen index and driving pressure, and there was no increase in barotrauma or mortality. So my take-home ideas for today are that the staircase recruitment maneuvers up to 35 centimeters of water in newborns imply very low risk for barotrauma. Please watch for bulla or congenital emphysema, and please avoid coughing during the pressurization phase. They also imply very low risk for hemodynamic impairment, but be careful in patients who might be hypovolemic. And they show improvement in right ventricular fraction after cardiac surgery. So lung recruitment maneuvers are important right before winning the pump. And please avoid sustained CPAP to prevent hemodynamic impairment, as just previously discussed. It is very important to allow enough time during pressurization phase. The patient might change response to recruitment maneuvers during admission to the PICU or during surgery. So if the patient doesn't respond the first time, that doesn't mean the patient is non-respondent. Just mean that at that particular moment he was not responding, but please allow a second chance before judging the patient as not responding. And my key message is individualize your recruitment maneuvers, either with long ultrasound, which is easily available and non-invasive, either with watching what's happening with hemodynamic, especially with ultrasymmetry. And if you have it available, EIT is going to be probably the gold standard in the next future years. So thank you very much for your attention. And if you have any questions, I will be very happy to discuss them with you. Thank you very much.